right patient management as case. And this I will be sharing, talking about in the form of few case-based scenarios. And then I'll be giving you the top 10 pearls out of my experience in this multidisciplinary discussion. And finally, I'm going to tell you the take-home message. So what is multidisciplinary discussion? So when a histopathologist encounters a lung biopsy, especially a benign lung biopsy, like an interstitial lung disease, just by seeing the slide alone, the pathologist will not be able to give you the complete diagnosis. Complete diagnosis in the sense a clinical, radiological, and a pathological diagnosis. So what the pathologist has to do is he has to correlate with the clinical features, he has to correlate with the radiology features, and then only then he will be able to, he or she will be able to sign out a complete report. So this communication or this dialogue between the pathologist, the clinician, and the radiologist is called as the multidisciplinary discussion. And this multidisciplinary discussion is the gold standard for diagnosing lung diseases, especially the benign lung diseases.
Hello.
That is the interstitial lung diseases. So
Hello.
hope I am clear about this.
Hello. Ma'am,
So
we can't see
what
your
is
screen.
the first thing that I have learned?
We can't see your screen.
As a pathologist, my responsibility as a pathologist. So the clinician, what we have to understand, the pathologist should understand is that the clinician goes for a biopsy, which is an invasive procedure.
Ma'am, your screen is not visible to us for online candidates.
No, it's visible. It's visible.
Yes, ma'am. Now it's visible. Thank you.
Let it be others. Keep it in the slideshow mode. If you keep it in the slideshow mode, then this will not disappear. It will remain there. So the clinician goes for a biopsy, which is an invasive procedure, only if he or she doesn't find the answers or can't make a diagnosis after performing all the non-invasive investigations like blood investigations, urine, sputum, and radiology. So my job, or our job as a pathologist, is to help the clinician and patient in getting the right diagnosis. So for this, I should talk to the clinician, the radiologist, correlate my findings with their findings, with the clinical features, the radiology features, and then sign out a clinical radio patho report, which is the final complete report. This we cannot minimize. That cannot be minimized. That will be their question, not here. So how does this report sign-outs happen in Mayo Clinic? So the pathologist reviews the clinical notes via the Care Everywhere software, which is there in the Epic software system. So this is the function which they have in the Epic software system. So the pathologist reviews the clinical notes from the care everywhere software. After that, wherever required, like especially in second opinion consults, the patient's details are shared via email to the radiologist. The radiologist reviews the images. No, that should be okay for the audience. This mode is fine, or should I put it in the slideshow mode? It's not visible for the Zoom users. Okay. So wherever required, the patient details are shared via email to the radiologist. The radiologist then reviews the images and discusses his opinion telephonically. After the radio paper correlation, if further information is to be sought or in case of discrepancy of the diagnosis, or if the diagnosis is a critical one, then the pathologist first discusses with the clinician telephonically. And then the final diagnosis is signed out. And a comment is given in the report incorporating all the patient's details, the radiology investigations, the lab investigations, and the relevant biopsy findings, which has led to that particular diagnosis. Sometimes, if not always a definite diagnosis can be made. So sometimes, if that definite diagnosis could not be given, then a list of differential diagnosis is mentioned in the report. So when additional tests are performed, then an addendum report is released later. So this is the sample report of the Mayo Clinic. This is how they sign out. So in the interpretation, first the final diagnosis is given. The site of the biopsy is mentioned first. Left lung, left upper lobe, needle core biopsy in this case, and the diagnosis here is acute and organizing alveolar hemorrhage. Changes compatible with ANCA-associated vasculitis following clinico-pathological correlation. See, one thing you have to note on this is that first the impression is given, that is the acute and organizing alveolar hemorrhage, and the underlying etiology, probable underlying etiology is also mentioned in the impression. Here it is changes compatible with ANCA-associated vasculitis. So this is the complete report where the entire the clinical features, the radiology features, and the biopsy features are correlated, and a final diagnosis is made. And then in the comment, these findings, the clinical features are mentioned, like in this case, history of gastroesophageal reflux disease, anemia of chronic disease, recent admission for hemoptysis. Then even the radiological features are also mentioned, multiple bilateral opacities by imaging studies. Then the other lab investigations are also mentioned. In this case, positive Bianca, high value MPO, and why the biopsy has been done. What is the primary concern for doing this biopsy is also mentioned in the comment section. Here it is primary concern is for ANCA-associated vasculitis versus multifocal adenocarcinoma in situ versus non-tuberculous infectious etiologies. Then the smoking status of the patient is mentioned. Patient is a lifelong non-smoker here. Then the Bianca studies, the anti-MPO, and the past history of an acute kidney failure and the relevant investigations have been mentioned. Then after mentioning all these features, then the next part, the biopsy features are mentioned, the positive features and the negative features. The negative features here are large vessel vasculitis is not appreciated, no necrotizing granulomas, no small vessel capillaritis, no neoplasms. And then finally, the final impression is given. Following clinical pathological correlation, the histologic findings are entirely compatible with ANCA-associated vasculitis. So then additional investigations have also been mentioned. Compulsory workup for infection, and that will be released as an addendum. This is the sample report of Mayo Clinic, how they sign out their cases. And MDD happens once in a month in Mayo Clinic, and every alternate Friday. I guess even now it is happening every alternate Friday at University of Washington. And I had the privilege to attend these MDD discussions with Dr. Ganesh Raghu sir and Dr. Sudhakar Pipawat. And they were like wonderful discussions. I was fortunate enough to attend those discussions with them. And so now I'll go to the case-based scenarios. The first one, the case scenario 1. So, Dr. Ratna, I need to go to the slideshow mode for this. So I'll just check whether they are able to. I think only this part they are not able to see. No, the slides are not moving. So case scenario 1, this is a 65-year-old male presented with progressive shortness of breath for the past 1.5 years along with cough. The imaging showed reticulation and evidence of interstitial lung disease. The provisional diagnosis was very idiopathic pulmonary fibrosis. So this is how the biopsy looked like. So can anyone identify this pathology residence? What is this picture showing? Is it normal looking or is it abnormal? Is it normal looking lung parenchyma? This is abnormal. This is definitely abnormal. There is architectural distortion. There is definite architectural distortion, and this architectural distortion is due to the presence of what is this? These bands, these pink bands. What are these? These are fibrosis. This is fibrosis. These are dense bands of fibrosis. So these dense bands of fibrosis are patchy. They are not diffused throughout the lung. Because here we could see these areas, the normal looking lung. Point. It's not. Is it working? It's not working. Mouse. Yeah, we are able to see this. So what are these pink bands? These are nothing but dense areas of fibrosis. So these dense areas of fibrosis, they are not uniform. They are patchy. Because here you could see there is this normal looking alveolar lung parenchyma. And here you find these honeycomb cysts. So this honeycomb cystic, this architectural this architectural distortion with dense fibrous bands with showing a patchy pattern with this honeycomb cyst. So now what is the pattern? Can anybody tell now? What is this pattern of fibrosis? It is UIP pattern of fibrosis, usual interstitial pneumonia pattern of fibrosis. So this pattern of fibrosis, as Dr. Sudhakar Pipawat has also mentioned, so this is the histological counterpart of the clinical idiopathic pulmonary fibrosis. So idiopathic pulmonary fibrosis on histology is equivalent to UIP pattern. But again, the reverse is not true. UIP pattern on biopsy doesn't always mean that it is IPF clinically. So hope you got my point. So clinically, IPF means UIP pattern on biopsy, but biopsy pattern of UIP doesn't always mean that it is UIP. It is always IPF because there are other entities also showing this UIP pattern of fibrosis. So, so from this, okay, UIP pattern of fibrosis going towards the provisional diagnosis of IPF. But in the other sections, the pathologist could find these areas as well. These areas. So what are these? What are these? Who are the pathology residents? Can you please raise your hands? No pathology residents? Okay, so the rest of the sections, in the other sections, the pathologist has found also these areas. So these are nothing but granulomas. You can find there are multinucleated giant cells as well here, few multinucleated giant cells and the lymphocytes. And these granulomas are non-necrotizing granulomas. There is no necrosis here. And these are vague granulomas and they are interstitial. What is the location of these granulomas? This is the interstitial granuloma. These are the alveolar spaces. This is the interstitium, and in this interstitium, you find these vague, non-necrotizing epithelioid granulomas. So the pathologist communicates this with the pulmonologist, saying that the biopsy shows usual interstitial pneumonia pattern of fibrosis, and along with that, he also found few vague, loose granulomas with few multinucleated giant cells around the bronchioles. So the pulmonologist then further probes into the history, and then the patient reveals that he keeps pet birds. So now, what is the final diagnosis? Is it IPF still? No. Now it is chronic hypersensitivity pneumonitis with UIP pattern of fibrosis. So this is the reason why I said like UIP on biopsy is not always IPF clinically. There are other entities like chronic HP which may which may cause this UIP pattern of fibrosis. So don't always, the pathologist should always should not be biased with the clinical diagnosis. So once if the pathologist gets biased with the clinical diagnosis, okay, with the first one step, he will say, okay, fine, UIP pattern of fibrosis I found in the biopsy, and this is correlating with the clinical diagnosis of IPF. And so let me sign out the report. And the pathologist is happy, the pulmonologist is happy because the pathologist is able to satisfy the pulmonologist, he or she is giving the right clinical diagnosis. So this is why it should not be always there should be a clinical and pathological correlation. So going to the next case scenario. This is a 65-year-old man presenting with increased dyspnea and weight loss of 3.5 kilos over a 4-month period. He has a past medical history of emphysema, seizure disorder, and hepatitis C, and the patient is on albuterol and dilantin. He also had a 35-pack history of smoking. His labs were normal. The CT scan showed a speculated opacity of size 4.5 to 2.5 centimeter in the medial aspect of right middle lobe, and the radiologist has given a suspicion of malignancy in this. So a EBUS, TBNA, and biopsy were done, and they were sent for histopathological examination. So this is what the biopsy picture looked like. So is there any malignancy in this? Is there a malignancy in these pictures? There is no malignancy. So this is negative for malignancy. And what are all these things which are present? These are all the blood vessels. These are blood vessels. And in this blood vessels, we find these polarizable crystals. So the same here under hyper. So these crystals which we are finding here, these are the polarizable crystals, and these are nothing but the talc crystals in the pulmonary blood vessels. So the pathologist says to the pulmonologist, it's negative for malignancy, but I could find few intravenous polarizable birefringent talc crystals with a foreign body giant cell reaction around. Now the pulmonologist probes into the clinical history, and then the patient gives a history that he is injecting heroin intravenously. This is a case when I was in, which was signed out when I was in US. So this is not from India. And so the final diagnosis is a talc granulomatosis. So what is the pearl in these two cases? So the biopsy findings can always give a clue to the clinician to investigate more and make the right clinical diagnosis.
The previous one, you said there is talc in the blood vessels.
Yeah.
So, inhalation of talc versus talc in the blood vessels. Talc in the blood vessels, there we think of excipient lung, where individuals crush tablets and.
Yeah, exactly. The patient has crushed the pills and then he injected it intravenously. So that's the reason why we are finding these talc crystals in the pulmonary blood vessels.
What were you going to say to that?
I didn't get you.
No, like in this patient, because in this patient, there were talc, there was talc granulomas or talc in the blood vessels,
Yes.
right? So generally, inhalation of talc, you still see them in the blood vessels?
No. We don't see them in the blood vessels. We don't see inhalational in the blood vessels. This patient was injecting those into the blood vessels. So that is the reason why we found these talc crystals in the blood vessels. And around that talc crystals, there was this foreign body giant cell reaction.
Yeah, I think just a quick, because it's published in that area.
Okay.
It's quite interesting, this is called excipient lung.
Exactly.
And excipient is also known as basically excipient is nothing but the buffering agent.
Yeah, the binding agent.
Yeah, but for people to get quite high, if they have opiates, they crush the tablets and then mix it and sitting in there.
Yeah.
And the tab is too big for it to kind of cross through the arterioles.
Hmm.
And then kind of give this intense intravascular, perivascular granulomatosis around the
Blood vessels.
artery.
Yeah.
The other substance is called crystalline calciumos,
Yeah.
which is also sizable and gets stuck in there. And then you get
Yeah.
that's a little bit different from as you
Yeah. So one is polarizable and the other one is not. Yeah.
And then usually the present with sudden onset severe pulmonary hypertension.
Hmm.
Did this person have?
No, this patient didn't have. The only thing is like the concern was of a malignancy, but again, means they were not able to find out like what is the reason. So they were like probing. This was a case when I was in Mayo. I think in the first week when I was in Mayo. So the patient was like, the clinician then went on probing, and then after that, finally, after more than a 15 minutes or 20 minutes of this one, then he revealed that like he was doing this. So yeah.
Quite interesting.
Yeah. Thank you for your comments. So going to the next case scenario. This is a 55-year-old female presented with 3 months history of increasing shortness of breath accompanied by non-productive cough. The imaging showed bilateral reticulation and ground glass opacities, and a biopsy was done. And biopsy showed the usual interstitial pneumonia pattern of fibrosis. And this time there are no granulomas, there is no giant cell. So what is the diagnosis? Based only on this history, UIP pattern of fibrosis with no granulomas, no giant cells, means no alternate diagnosis. Then what is the diagnosis? IPF. Fine, great. Yes, IPF. But IPF, can it occur in a 55-year-old female? Unlikely, yes. So now the pathologist is aware of the fact that IPF is very unlikely to occur in a 55-year-old female. Now he communicates with the clinician, and the clinician then gives the history that the patient has a PET burn. Then he communicates with the radiologist, sees the radiology, the HRCT pictures, and he finds that there are ground glass opacities and mosaic attenuation and air trapping, mostly in the upper and middle lobe predominance. So now he takes deeper sections and he is like, hooray, and now he found the culprit. So what is the culprit? This is the culprit. So what is this again? What is this? Granuloma. It is again a non-necrotizing granuloma in the interstitium. You find there are these lymphocytes and then these few multinucleated giant cells. So interstitial non-necrotizing vague granuloma, epithelioid granuloma. So now the diagnosis is what? It is a fibrotic hypersensitivity pneumonitis with UIP pattern of fibrosis. So all these slides actually I have put animation. They come one by one, but unfortunately we are not able to do this because the Zoom participants are not able to see the slides when it is put in the slideshow mode. So I have to put it in this mode and show you.
Just for considering for 1 second, you can put it on the slide.
Yeah, sure. Yeah.
And then go back. Just from current slide.
Yeah. So this is how. So IPF in a 55-year-old female, the pathologist communicates with the clinician. Clinician gives the history that the patient has a PET burn. And then he correlates with the radiology. Radiology shows there is ground glass opacities, mostly in the upper and middle lobes. And then he takes the deeper sections, and in the deeper sections, he found this culprit. That is the interstitial vague non-necrotizing granuloma. And now the diagnosis is fibrotic hypersensitivity pneumonitis with UIP pattern of fibrosis.
So this is interesting. Is it okay if I make a few comments?
Yeah, sure.
So, normally when you look at something like this, obviously the patient will go to one of the pulmonologists, will take a detailed history for HRCT, and the HRCT is obviously alternative diagnosis, or maybe there was enough lobular air trapping, which it seems like it does have that pattern. If that is the pattern, then obviously the buck stops there. You wouldn't generally jump on to biopsy. I think maybe some of our computerized colleagues can comment, they might do a lavage, right?
Okay.
If they find lymphocyte predominant bronchial lavage, and also get that history of patient data having a bird.
Hmm.
I think that is the usual path.
Yeah.
But in this case, was there the biopsy was already done outside, and then the whole thing unraveled, or because this wouldn't be the usual pattern.
This wouldn't be the usual pattern if the patient gives the history of a bird already before the diagnosis. Yeah.
Standard protocols, right? But in India, this is perfectly possible, right? It's quite possible that they haven't even seen a pulmonologist, they could have just looked at another condition, could have ordered an X-ray, and they might not even have had it accessibility. So watching this is perfectly reasonable in the Indian context because it happens for the long time.
Yeah.
If you just possibly I'm sorry, I'm sure Dr. Vijay Kumar would agree, even pulmonologists are not exactly proven, right? As pathologists, we have to follow and see if there are specific exactly suggested for UIP. We didn't get very UIP younger patients, female patients. So all parts of those areas. Maybe from the standpoint for universe in the US, what you say with that?
So recently I
So the question here, like the requirements of what you say, and that a lot of things do happen which don't go like, was this a case for male clinic or? Yes.
no. This is the case here in the Indian this one only Indian scenario, and again another case I wanted to share. Like recently I got a sponsored case.
This one quickly on this one.
Sure.
So how did the patient arrive at biopsy? Is my question, like, who did somebody call UIP or like we put this called an alternate diagnosis on the imaging, and then they went straight to biopsy. Like, would anybody get a lung biopsy without pulmonary medicine person intervening in between, or that?
So basically, the patient didn't give the history of a bird in the first instance. So, like after the biopsy, then suggesting that this could be the HP. Only then, the patient was probed into the. This happens pretty commonly in Indian scenario because
Wouldn't it be intervened by bronchoalveolar lavage?
bronchoalveolar lavage is. I don't think it is specific to call it HP. We cannot call HP, especially when there is any infection. Infection like if the neutrophils are predominant. So neutrophils predominant doesn't mean that it is going in favor of IVF, isn't it?
Generally, in this scenario, I completely agree with the other. So, if we would have subjected to a ball, if it is lymphocyte, we can avoid a biopsy comfortably. And then that's most of the times, I can say 9 out of 10 cases, it turns to the HP rather than any other alternate. The patient doesn't respond, then we can think of doing a biopsy.
So lymphocyte predominant can also occur in sarcoid. So then how can you confidently call it as HP?
That's the very reason we are seeing, okay, for MDD. So looking at the CT pattern, I don't agree that this favors at any way close to sarcoid. That we see it.
So I think there are, for something to reach pathology when there shouldn't have been any pathology, there are several kind of missteps may have happened. And
So in some cases where the bowel, suppose the patient has a infection, there is infection. So in such cases, it will not be a lymphocyte predominant, it will be a neutrophil predominant. Even this also I have seen.
No, so if you look at the ATS document, the clinical predisposition, generally, let's say an ideal scenario for this case. Obviously, you're suggesting that there's no ideal scenario here, and but mistakes do happen, and genetic mistakes as well. But the point I'm trying to make is the ideal scenario.
Yeah.
Let's say the patient doesn't fit the right demographics for India. She's a 55-year-old lady. So you would think about autoimmune immunology, or you would think about, say, having some kind of exposure, right?
Yeah.
So before going to biopsy, the patient would have sought with a pulmonologist, right? Some pulmonologist would have given green signal to go get the tissue. And if they had done lavage and if it was lymphocyte predominant, then they would ask the proactive question: do you have words, or do you are you getting exposed?
No, not always, not always,
No, they don't do it, but that would be the
not always. It's interesting because, see, like even retrospectively, I have to tell the pulmonologist, like when I inquire, this happened very recently, consult case, where the diagnosis that was given by the clinician to me, the provisional diagnosis was silicosis. So they had a query of silicosis because the patient works in some granite industry and all. So when I've seen, then it was a typical, interstitial non-necrotizing vague granuloma. Then I asked the pulmonologist, like, what is the history? Does the patient give any history of, keeping bird exposure? Then he said, no, there is no exposure. I said, no, you please go and take the history again. And then you come back to me. Then he took the history because prior to that, his residents have taken the history. So then he probed into the issue.
Actually, I think the explanation has cleared some confusion because initially there was suspicion is about the silicosis. So silicosis is like more emphasis coming. So that is why biopsy was ordered. It's not because that they suspected hypersensitivity. So if that was the case, it would have been ended with bar. I agree with that.
No, that is a different case. Silicosis was a different case.
Okay.
Silicosis was a different case. That is a recent case which I have signed off. Yeah, not this one.
Shall we move on to the?
Yeah, thank you. So the pearl number 2, in this case scenario, so the pathologist should be aware that the clinician doesn't go for a biopsy if there is a definite case of, if it is a definite case of idiopathic pulmonary fibrosis. That is what Dr. Sudhakar has also talked in his talk. So when there is a definite diagnosis of idiopathic pulmonary fibrosis, the clinician will not go for a biopsy. Biopsy is done only if he suspects an alternate diagnosis. So the pathologist should not directly, if the pathologist is in a dilemma about the diagnosis, he should not sign out the report with a descriptive diagnosis. He should always communicate with the clinician and radiologist and only then sign out the report. So this is the pearl for this case. So hope I'm clear on this. So we'll move on to the next case. So this is a 50-year-old man. He complains of weakness, low-grade temperature, and symptoms of an upper respiratory tract infection since 5 weeks. He had an initial response to antibiotics and subsequently became symptomatic with a temperature of 104 degrees Fahrenheit and was admitted. Workup at this time showed mild anemia, increased platelets. Sputum cultures were negative for bacteria, fungi, and AFB. Chest radiographs showed consolidation of the left upper lobe, pleural effusion, and bilateral alveolar infiltrates. So a needle core biopsy was done in view of suspected malignancy. And these are the biopsy features. So what is this? Yeah. So this is what the biopsy showed. So the biopsy showed this. This is again a granuloma. This is a necrotizing granuloma. But here the granuloma, this necrosis is not the pink eosinophilic granular necrosis of a tuberculous granuloma. This is a dirty necrosis, dirty blue necrosis. And this necrosis is due to the presence of neutrophilic debris, neutrophilic abscesses. And surrounding this, you find these are the epithelioid histiocytes in a palisading way and few multinucleated giant cells here and there. So these granulomas are present. Along with that, the other sections reveal this finding. So what is this finding? So these are the capillaries, and these capillaries are infiltrated. All of these capillaries are infiltrated by neutrophils. So this is called as capillaritis. So capillaritis is always a red flag sign. So what is the diagnosis? These dirty necrotizing granulomas with this dirty blue necrosis and capillaritis. The diagnosis is diffuse alveolar hemorrhage. So diffuse alveolar hemorrhage always there should be a prompt intimation to the clinician, as it may sometimes lead to a sudden massive bouts of hemoptysis and the patient may succumb quickly. So if the pulmonary pathologist immediately communicated to the clinician and a further workup was suggested, the serology and urinary sediment and C-ANCA was positive and the case was signed out as granulomatosis with polyangina. So this is a case of GPA, or previously it was called as vaginal granulomatosis. So certain conditions are critical alerts and they warrant an immediate phone call to the clinician by the pathologist, as these patients need immediate therapy. So in Mayo, they used to tell us, do not leave such cases on Friday evening, because Saturday and Sunday are off for them. So do not leave such cases on a Friday evening for a Monday morning reporting. The patient may die over the weekend because of the massive bouts of hemoptysis which may occur in such patients. So going to the next case scenario. So this is a 55-year-old patient with a history of some infection, and this is what the biopsy showed. So what is this finding? These branching structures here, this is all the alveolar lung parenchyma, and there are a lot of inflammatory infiltrate here. Along with that, these structures are found. So these are nothing but these branching structures. These are fibroblastic proliferation in myxoid background, and these branching structures are called as organizing pneumonia polyps. So these are fibroblastic polyps of organizing pneumonia. So these polyps of organizing pneumonia are seen in the proliferative phase of acute lung injury of any etiology. So these cases, if they are found out by the pathologist as organizing pneumonia, there is some of the clinicians may think that it is a cryptogenic organizing pneumonia, for which the treatment is steroids. And the patient might be wrongly treated by steroids, but the underlying etiology could be something else, like an infection. So always it is better to use a terminology which the clinician can understand. And in this context, in this case, the better use the term A-space organizing pneumonia organization, A-space organization, instead of calling it as organizing pneumonia. So the call here is the clinician, the pathologist, and the radiologist should understand each other's terminology and what they exactly mean in their reports when a particular term is used. So hope Dr. Vijay Kumar agrees with this point, because this was the issue which I actually faced when I signed it out as an organizing pneumonia. Immediately I got a call asking me, Madam, is this, do you think that it is cryptogenic organizing pneumonia? Then I had to explain that it is not cryptogenic organizing pneumonia, it is organizing pneumonia of some underlying infection. So going to the next case scenario. This I have to put it in an animated mode again in the slideshow. So a 65-year-old male, suspect of lung cancer clinically, underwent a diagnostic biopsy. Immunohistochemistry was performed. Diagnosis was established as non-small cell lung carcinoma favoring adenocarcinoma. Now there is no material left for molecular testing. As you all know, if it is signed out as non-small cell carcinoma favoring adenocarcinoma, the patient should undergo further testing by molecular studies. So in this case, there was no material left for molecular testing. So a repeat biopsy was done only for this molecular testing, and this time it was sent to another lab. But the purpose was not communicated to the pathologist. So the purpose of the rebiopsy was not communicated to the pathologist. So the pathologist has started his diagnostic workup again, right from basic H&E, then immunohistochemistry. Then again the tissue got exhausted, and then there is no tissue left for molecular testing, leading to the frustration for the clinician and also the patient. So the clinician should always inform the pathologist, and also the pathologist should know the indication for of the biopsy. So what is expected of him for whether it is diagnosis or molecular testing while sending any special or precious sample like a molecular priority sample, like in this case. So this reduces unnecessary wastage of the tissue by trimming in the attempt to make a diagnosis, and also doing unnecessary IHC for further subtyping. So which is what happened in this case. The pathologist didn't know The indication for the biopsy, the pulmonologist also didn't communicate to the pathologist, saying that this time the biopsy was done only for molecular testing. So this is the case. I'm going to the next case scenario. So this is a 65-year-old female, known case of asthma, presented with 1 week history of moderate chest pain and dry cough and intermittent fever since 1 month. So this is how the biopsy looked like. So these are all the alveolar spaces, and this is the alveolar septum, and these alveolar spaces are filled by these inflammatory cells. And on closer view, these inflammatory cells are found to be eosinophils. So these are the eosinophilic microabscesses along with few multinucleated giant cells. So female patient, known case of asthma, and with this eosinophils, alveolar filling by this eosinophils, the diagnosis is chronic eosinophilic pneumonia. So both acute and chronic eosinophilic pneumonia typically have a favorable response to corticosteroid therapies. So in such cases, the diagnosis should be made promptly on biopsy, even when few eosinophils are seen in hyper in the appropriate clinical and radiological context. So this we have to keep in mind that prior treatment with steroids in such cases may greatly reduce the number of eosinophils. So that is why when there is proper clinical and radiological context, always go to the hyper and look for the eosinophils. Even if you find few eosinophils in the biopsy, then sign up the case as eosinophilic pneumonia, because these patients will benefit from corticosteroids. So the pearl in this case is certain conditions will diagnose promptly, could be treated promptly and completely. So never misdiagnose such cases. So going to the next case scenario, this is a 22-year female. This is also a consult case which I got from Mumbai. She is a young female, 22-year female with dry cough and shortness of breath since 7 years. The CT showed bilateral ground glass opacities, and there was mediastinal lymphadenopathy. And this is what the biopsy showed. So the biopsy here is showing these, again, these are the alveolar spaces, and these alveolar spaces again are filled by inflammatory cells. And closer view of these inflammatory cells are, these are nothing but dense lymphoid infiltrates. So the diagnosis here is lymphoid interstitial pneumonia. So here again, there will be, I think, a tug of war between me and Dr. Sudhakar. So in radiology, the diagnosis of lymphoid interstitial pneumonia is made when there are bilateral thin wall cysts. But often these cysts which are seen in imaging are not identified on histology. So the pathologist should know about this discrepancy in such cases where, you know, the radiology shows something and the pathology of the biopsy shows something else. So in this case, the biopsy showed dense lymphoid infiltrates in the interstitium, and there is only one condition showing this LIP, that is Sjogren's. Only in Sjogren's, the radiological LIP actually correlates with pathological LIP, meaning along with this lymphoid infiltrates, we find even the cyst only in Sjogren's syndrome. But the rest of the etiologies of LIP, we do not find cysts. This is because maybe the biopsy is done in other areas upon leaving the cyst, or maybe the cyst might have collapsed during the procedure. So this is the reason why we did not find cysts on the biopsy, but the radiology shows cysts. So this is the pearl. Some conditions, they show discrepancy between radiology and biopsy findings. So not always, like most of the cases, the biopsy findings do correlate with the radiology findings, but there are certain conditions like this where there is a discrepancy, and this we have to keep in mind. So going to the next case, she is a 35-year-old female presenting with breathlessness and cough, and the chest CT shows a suspicion of interstitial lung disease to rule out pulmonary alveolar proteinosis. The patient also had diffuse pruritic rashes all over the body, but there is no history of joint pains, muscle weakness, dry mouth, dry dysphagia, fever, loss of appetite, weight and appetite. So all these are negative. The ANA studies, the Zianka, Pianka, and the anti-CCP are all negative. A BAL was performed and it is negative for pulmonary alveolar proteinosis and also infections. So a cryobiopsy was done and it was sent for histopathological examination. And this is how the biopsy looked like. So what is this? Can anyone identify this pattern? So is there architectural distortion in this picture? So this architectural distortion is homogeneous or heterogeneous? So architectural distortion is due to the presence of fibrosis. So these are all the alveolar spaces, and in between the alveolar spaces, this is the alveolar interstitium, and this alveolar interstitium is widened, it is thickened with inflammatory cells and also fibrosis. But this alveolar thickening is homogeneous in this case, unlike the UIP pattern where it was heterogeneous. So homogeneous thickening, homogeneous pattern. There are also few lymphoid follicles. See, these are all the lymphoid aggregates. These blue ones. These are the lymphoid aggregates, and some of them are showing these germinal centers also. Apart from that, this is the pleura. There is pleuritis. There is inflammation of the pleura and also pleural fibrosis. So what is this pattern? Homogeneous thickening. This is a non-specific interstitial pneumonia pattern. So UIP is heterogeneous, NSIP is homogeneous. So remember the cars pictures that Dr. Sudhakar has shown us. So the cryobiopsy showed a non-specific interstitial pneumonia pattern. So extended serology was suggested. A myositis profile was also suggested. And then anti-SAE1 antibody was strongly positive. So the final diagnosis was anti-SAE1, that is anti-small ubiquitin-like modifier activating enzyme dermatomyositis was associated ILD was signed out. So the call in this case is pathologists should know that NSIP pattern most often is due to an underlying connective tissue disease. So even if the basic serology workup, the initial basic serology workup is negative, the pathologist should suggest an extended serology profile. So like in this case, the extended serology means the anti-SAM antibody has come out to be positive. So going to the next case scenario. So this is the 54-year-old male. This is also a consult case which I got with shortness of breath since a month. And this is what the biopsy showed. So what are these? What are these? This is the hyperview of the same. This is the hyperview. So these are nothing but epithelioid granulomas. These are non-necrotizing granulomas. And see the distribution of these granulomas. These are in the interstitium and also in the bronchovascular, closer to the bronchovascular bundle. This is the bronchovascular bundle with the bronchiole and the blood vessel here. This is the bronchovascular bundle, and these are closer to the bronchovascular bundle. So typically they are showing this lymphangitic distribution. So non-necrotizing granulomas in the lymphangitic distribution, the most common causes sarcoid. So this is another picture showing the sarcoid granulomas. And see this picture. Here also, these are also the granulomas. These are also granulomas, but these granulomas are not showing the typical lymphangitic distribution. They are randomly placed. And when you do this AFB is positive. So these are the tuberculosis granulomas. So distinguishing sarcoid from TB may not always be possible with 100% confidence on a biopsy unless we do a Zeden stain which comes out to be positive. Distinction may be possible in a surgical lung biopsy due to the presence of other features like pleuritis, lymphangitic distribution, well-formed granulomas, normal appearance of the lung parenchyma in between the granulomas. So in such surgical lung biopsies where they are showing these additional features, then we can confidently give a diagnosis of sarcoid, but not always. Sometimes this distribution is difficult to identify in small biopsies like transbronchial lung biopsy due to the small sample size. If there is caseous necrosis, if AFB is positive, then confidently we can call it as tuberculosis or not sarcoid. But only with the presence of these granulomas, even if the granulomas are non-necrotizing, especially in small samples, we cannot confidently call that as sarcoid or sarcoid. So here the call is distinguishing sarcoid from tuberculosis may not always be possible with 100% confidence in a biopsy, and it always needs clinical and radiological correlation. The diagnosis of sarcoid could only be suggested in the report in the appropriate clinical and radiological context. It can only be suggested. So going to the next case scenario, a 41-year-old male. presented with history of dyspnea, cough, and persisting lung infiltrates. He complained of intermittent low-grade fevers without associated chills or night sweats. He was initially treated with several courses of antibiotics without resolution of symptoms or the interstitial infiltrates. His medical history is notable for GERD, gastroesophageal reflux disease, for which he was on esomeprazole. Because of his occupation and the presence of airway-centered granulomas in the biopsy, hypersensitivity pneumonitis is thought of by both the clinician as well as the pathologist. And the patient was empirically treated with prednisolone. But after 12 weeks of therapy, he was not improving, and hence the biopsy was sent out for the second opinion consults. So then the pathologist reviews the slides thoroughly, talks to the clinician. Clinician informs him about the history of gastroesophageal reflux disease, sees the radiology. Radiology did not reveal any mosaic attenuation, air trapping, which are actually the features of HP. So there are no features of HP, but there are gravity-dependent obesities. So deeper sections were taken. And this is what the deeper section has revealed. So what is this? Yeah, what is this? Any guesses? What is this? Huh? This is nothing but the aspirated vegetable material. So this is the case of aspiration pneumonia. So this is the significance of communicating with the clinician and with the radiology features. So clinician gave the history of GERD. Radiology didn't show any features of HP, but they showed gravity-dependent obesities. So this has led the pathologist to take deeper sections which revealed this finding. And then the right diagnosis of aspiration pneumonia was made. So coming to the last pearl number 10, don't be in a haste to make a diagnosis. Always correlate biopsy findings with the clinical and radiology findings to make the right diagnosis, which helps in the right patient management. So with this, I end my talk giving you the final take-home message. Clear communication is the key. Clear communication between the clinician, the radiologist, and pathologist to arrive at the right diagnosis. So pathologists should also be aware of why the biopsy is done, what is the indication of the biopsy, and what answers the pathologist, the clinician is expecting from the pathologist. So this is the Mayo Clinic campus. This is the Phoenix building, and this is the Scottsdale campus. And these were my mentors, Dr. Henry Tausler, Dr. Maxwell Smith, and this was Christoph, my fellow colleague from Germany. This is Dr. Harika, this is Dr. Yasmin Bhatt. And yeah, I would like to invite all of you to register for this web series, Diagnostic Pulmonary Pathology web series, conducted by Association of Pathologists, Thoracic Pathologists. So we have finished successfully 3 seasons. We are doing this since 3 years. Season 1 to 3 we have completed, and now we are starting with season 4 from June 1st. And this is my team. Dr. Deepa, Dr. Roma, and Dr. Pradeep Vaidishwar. And so these are the faculty of non-neoplastic lung biopsy, lung pathology module. And this is the faculty of neoplastic lung pathology module. We have Dr. Yasmin Bhatt from Mayo Clinic, Dr. Siddharth Pipawat. We are highly honored to have him in our season. And Dr. Irini Sanzino from Spain, Dr. Sanjay Mukhopadhyay from Cleveland Clinic, Dr. Bolan from Mayo Clinic, Dr. Pradeep Vaidishwaram from KEM Hospital, Dr. Politi from Italy. This is me, Dr. Kumar from Tata Memorial Hospital, Dr. Sinjita Roy from MD Anderson Cancer Center, Dr. Yale Rosen from New York, Dr. Larson from Mayo Clinic, Dr. Matthew from Ontario University, London, Dr. Raghavendra from Virginia Commonwealth. So if you need any further details, you can always write to me. This is my email address. This is my WhatsApp number. And the flyer is also available in Patho India website. So with this, I thank all of you, especially Dr. Siddharth Pipawat, for obliging my request to come for this, to attend, to give a talk in the CME. I'm highly honored and privileged. I talk Dr. Ratna Gosai for organizing this, Dr. Arna Madam, Dr. Surinder Reddy sir, Dr. Krishnakant sir, Dr. Naveen, Dr. Ranjini madam, and the entire team of ESI Hospital for organizing such a wonderful CME. So wish you all a very happy lung learning, and thank you so much.
Thank you, Dr. Sharada. Now I request Sharada to come.
Thank you, Dr. Sharada. We really enjoyed that. I must really commend the efforts. Actually, they started this really to cover. Here on the ground, Indian pathology is at least 25-30 years behind the rest of the world. Very underrecognized. I trained and worked for a very long time in the UK for a significant chunk of my professional life. So I know how it is. The reason why I even came back was to set up a really sufficient world-class lab. I know how under-recognized it is. So what you say is perfectly possible. I also have a standalone lab, so we get random samples in the back of the boulders. Right? Certainly, neither the pulmonologist nor an radiologist are going to do it. So you can see the need for training. So we should really thank you for taking this effort and coming here, and I'm sure everybody, all radiologists, all pathologists, every single person here has greatly benefited by this. My take home message would be for all budding pathologists and radiologists, we are a kind of supportive service. So we are on the phone, right? For every single case. Obviously, IIT is very specialized, that require more correlation and maybe other things, but virtually every biopsy does require correlation. We are forever on the phone with our patients, and we don't really send out the biopsy unless we are sure. So that would be my take home for all the residents. And then one final thing on PD was stuff and constantly talking about this. Even when PD is microbiology that are molecular diagnosis, it's really not histopathological diagnosis. It's not only in the context of now, PD versus alpha. We constantly see it in the GI tract, where granulometasolitis is known as PD. So as a routine, we advise TB PCR gene to all our samples. Plus, our take home is always when in doubt, pay for TB. So thank you.
Thank you, Dr. Sharada. And now I request Dr. Vishesh sir, please to come on to the dais to hand over memento to Dr. Sharada. Now I request Aruna ma'am, please hand over memento to Ranjini ma'am. Before proceeding on to the next case discussions, I apologize for the delay. There are some technical glitches, and thank you all for waiting so patiently. So without not wasting much time, we'll proceed with the first case discussion. Yeah. Over to Aruna ma'am.
Thank you, ma'am. Good evening, everyone. So my apologies to keep you beyond the scheduled time. But I promise that you will benefit from these discussions. And we have with us Dr. Vishesh, who's all seen through all the cases which are being presented. And when it comes to the multidisciplinary approach, so it is not new for any one of us here, because this is an umbrella setup. Our hospital has everything, all specialties under one roof. And we also have, like what the Mayo has, the Epic software. We also have the eSanjeevani. And now you understand why it is important to properly enter all your findings into that software. And Yes, now and then we do have some technical glitches. I keep calling Dr. Shaktidasan sir, what you're able to see in your ID, we are not able to see the report. So sometimes it happens, but on a daily basis, this multidisciplinary approach is happening because whatever we need, our residents just go down, take the steps to the radiology department along with the patient to see what is actually the scenario is. And also it is like they have to just cross across the road to reach the pathology department. And whenever I talk to Dr. Krishnakant sir, he says, yes, madam, your residents can walk in and see the slides, but just have to inform me one day before. I'll keep all the slides aside. Now after listening to the talks of the specialists here, all the residents, I think they have understood, like, why, how the radiologist is thinking, what is the thought process of the radiologist, what is the thought process of the pathologist. So whenever we want to take the case to the bronchoscopy, they say, ma'am, still we didn't get the report, CT report. So we are waiting for the report. Now, you know how many inputs are there, how many calculations are there to arrive at a report. And whenever the pathologist is having a doubt, he is calling, you are asking, madam, pathologist, we received a call from the pathologist. No, they are asking more history. So what is that to supplement? You know the importance. And what the cases now our residents are presenting is what they have done. These are the cases that they have seen and they have worked out. It was only within 2 days time they prepared all these things, and it was only 1 day for integration. So they're not like the specialists who have presented the case. So I invite Dr. Kavya to start her presentation.
So panelists for this case discussion, apart from our expert speaker, Rama Pajanachi, and we have our regional speaker, Dr. Vishesh, and Dr. Krishnakant, Professor in Engineering of Technology. Just before we start our presentation, President Dr. Vijay Kumar from Apollo Hospital, sorry, I introduced you today. Welcome to the session, sir. Thank you for the inputs. One of the senior colleagues, I think, so many of you all can move. That's a very needed introduction.
Can I start? Good evening, everyone. I'm Dr. Kavya, second year postgraduate from the Department of Pulmonology. I'm here to present the first case scenario. So let's go with the first case. An 18-year-old male, he got admitted with complaints of dyspnea on exertion since 4 months, which is of MMRC grade 2, dry cough since 6 weeks, headache since 4 weeks, which was episodic 1 to 2 times per week. History of night sweats were there 4 weeks back, and history of central chest pain 6 months back. Past history of hospital admission 1 year back in view of dengue and typhoid infection was there, and there was a history of viral fever 1 month back, and he had no addictions. On examination, the patient was conscious, coherent, cooperative, poorly built and nourished. BMI was 13.8 kilogram per meter square. There was no clubbing. Vitals were stable. On head-to-toe examination, hypopigmented macules over anterior chest wall, anterior and posterior aspect of neck was found. Local examination, about 0.5 to 0.5 centimeter round mobile swelling, soft in consistency, palpable in neck, anterior to sternocleidomastoid muscle bilaterally, about 1 centimeter inferior to angle of mandibles, which suggested of bilateral upper jugular lymph nodes, and 0.5 centimeter into 0.5 centimeter round mobile swelling, soft and